Hello friends, today we are going to discuss about the status epilepticus management. So status epilepticus is the second most common neurological emergency following ischemic stroke. Its incidence rate varies from the among countries ranging from 4.6 to 41 per 1 lakh per year. Mortality rates in adult with status epilepticus can reach 30%. Prompt recognition and the early treatment are thus necessary to reduce the morbidity and mortality. So about definition, American Epilepsy Society defined status epilepticus as either continuous seizure activity lasting more than 5 minutes or occurrence of two or more sequential seizure without complete recovery of consciousness between them. A few years earlier, uh, the Neurocritical Care Society provided a definition for status epilepticus as ongoing clinical and electrographic activity, specifying that status epilepticus is characterized by either continual clinical and electrographic seizure activity lasting 5 minutes or more, or recurrent seizure activity without recovery between the seizures. So pathophysiology. Pathophysiology of status epilepticus involves several mechanisms that ultimately lead to neuronal injury and death. Prolonged convulsive seizure lead to modification in bodily functions such as significant alteration in blood pressure, heart rate, respiratory performance, electrolyte level, blood sugar, and body temperature. During initial phase of convulsive status epilepticus, the cerebral blood flow increases, accompanied by tachycardia, high blood pressure, and dilatation of cerebral blood vessels. Although glycemia increases initially, there is subsequent surge in the lactate level and acidosis due to greater demand for energy, leading to increased anaerobic metabolism. So, some neuronal damage occurs as a result of physiological dysregulation, energy. Injury can also occur in a physiologically stable but seizing brain. The excessive activation of glutamate receptor and subsequent calcium influx into neuron caused by epileptic activity alone can result in neuronal injury and death. The cortex, cerebellum, and hippocampus are susceptible to lesion caused by prolonged convulsive seizure, which exhibit similar pattern to that observed in case of circulatory arrest, systemic hypotension, or hypoglycemia. Although some neurological damage occurs as a result of physiological dysregulation, injury can also occur in physiological stable but seizing brain. The excessive activation of glutamate receptor and subsequent calcium influx into neuron caused by epileptic activity alone can result in neuronal injury and death. Prolonged seizure and seizure-like activity lead to internalization and subsequent reduction of gamma aminobutyric acid beta receptor in the synapse. Internalization process of GABA A receptor was shown to be modulated by neuronal activity, with recurrent bursting enhancing it and the blockage of neuronal activity reducing it. The internalization was associated with decreased response to GABA, while inhibition of internalization was linked to increased response to GABA. Conversely, N-methyl D-aspartate receptor were found to accumulate in the synapse during status epilepticus. This resulted in the progressive decreasing functionally active GABA A receptors and increasing functionally active NMDA receptor in the postsynaptic membrane soon after the onset of status epilepticus. This finding might clarify the gradual pharmacoresistance to GABA A receptor, allosterone, modulators, and increasing pharmacosensitivity to NMDA antagonist. So, this figure is showing definition of status epilepticus with two operational dimension according to 2015 ILAE definition. So T0 indicates seizure onset. T1 is the operational dimension one time when seizure is likely to be prolonged, leading to continuous activity. and T2 is the operational dimension when seizing may cause long-term consequences. So the classification of status epilepticus can be based on its semiology, duration, and underlying etiology. Since status epilepticus is defined basically as a prolonged seizure, there can be as many forms of status epilepticus as there are types of seizure. To simplify and emphasize the severe form of status epilepticus, the Neurocritical Care Society proposed classification based on semiology criteria, that is, presence or absence of motor symptom and retention or impairment of consciousness. So, the first is generalized convulsive status epilepticus. It is characterized by tonic-clonic movement of the extremity and impairment of mental status such as coma, confusion, or lethargy. Focal neurological deficit can be observed in the post-ictal period. Convulsive status epilepticus makes up to 37 to 70% of all forms of status epilepticus. Non-convulsive status epilepticus is characterized by the seizure activity detected on the EEG, but without observable prominent motor symptoms. This type of status epilepticus is complex since there are several types ranging from absent status epilepticus to non-convulsive status epilepticus in coma, complicating severe brain injury. Furthermore, non-convulsive status epilepticus might also be seen after controlled generalized clonic status epilepticus and is common in intensive care setting. It is important to recognize all non-convulsive status epilepticus subtypes such as absence, aphasic, autonomic, and subtle because each requires different management approach and might be related to very different outcomes. However, they all require the use of EEG for diagnosis. Patients who fail to respond standard treatment regimen for status epilepticus are considered to have refractory status epilepticus, which involves appropriate doses of initial benzodiazepine followed by anti-seizure medication. So, super refractory status epilepticus is defined as status epilepticus that continues 24 hours or more after onset of anesthesia, including those cases in which status epilepticus recur on reduction or withdrawal of anesthesia. Now, etiology. While anti-seizure medication has been widely studied for their ability to stop seizure, it is also crucial to promptly diagnose and address any underlying causes. Various underlying factors such as alcohol withdrawal or intoxication, infections, severe metabolic disturbances, cerebrovascular events, and brain tumor related event require immediate and specific treatment beyond anti-seizure medication. A timely identification and underlying cause of seizure activity would facilitate more targeted treatment. So the etiology of status epilepticus is divided into two broad groups, that is known or symptomatic and unknown or cryptogenic. Within symptomatic group, the cause can be acute symptomatic, remote symptomatic, or progressive symptomatic, depending on the temporal relationship between the cause and the onset of status epilepticus. The known disorder can be caused by structural, metabolic, inflammatory, infectious, toxic, or genetic factor. Acute symptomatic causes are the leading etiology, making up approximately 48 to 63% of all status epilepticus. Among these cases, stroke emerges as leading cause, accounting for 14 to 22% of status epilepticus in adult. Furthermore, in older patients, prior stroke plays significant role as a contributing factor. Overall, significant proportion of patients diagnosed with status epilepticus have prior history of epilepsy ranging from 30% to 44%. Also, status epilepticus may occur in individuals who have previously been diagnosed with epilepsy or in those who experience it as first symptom. sometimes called as de novo status epilepticus. Among adults with history of epilepsy, the primary cause of status epilepticus is typically low level of anti-seizure medication. In most cases of status epilepticus, the underlying cause can be determined. However, there is subset of cases, roughly 5%, where the cause can be identified despite comprehensive work. This category is now referred to as cryptogenic status epilepticus in updated ILAE classification system. Hence, the term unknown origin or cryptogenic is used in its original sense of having unknown cause without presuming it to be symptomatic or organetics. The term idiopathic or genetic are non-applicable to the underlying etiology of status epilepticus because even in genetic epilepsy syndrome, the cause of status epilepticus may not be the same as the disease. Metabolic, toxic, or intrinsic factor can trigger status epilepticus in this syndrome. So the term new onset refractory status epilepticus was coined to describe the group of patients who share certain common modalities and yet often found to have varying etiology. So new onset refractory status epilepticus. It is a clinical presentation, not a specific diagnosis. In patients without active epilepsy or other pre-existing relevant neurological disorder with new onset refractory status epilepticus without clear acute or active structural, toxic and metabolic cause. Febrile infection and related epilepsy syndrome. It is a type of new onset refractory status epilepticus that is characterized by febrile infection that occur between 2 weeks to 24 hours before the onset of refractory status epilepticus. This febrile infection may or may not be present during the onset of status epilepticus. The study revealed that cryptogenic causes were responsible for 49.9% of cases, while autoimmune factor accounted for 36.2%, making it most prevalent cause. Approximately 10% of new onset refractory status epilepticus cases are caused by infections, with virus being most commonly implicated pathogen, depending on the region's endemic agent. The onset of new onset refractory status epilepticus can be attributed to genetic and congenital disorder along with toxic, vascular, and degenerative conditions that have been reported. The overall mortality rate was recorded at 22%. The frequent employed treatment encompasses the administration of anti-seizure medication, general anesthesia, as well as immunotherapy such as corticosteroid, intravenous immunoglobulin, and plasma exchange. The average duration of intensive care unit stay was recorded as 33.4 days, and upon discharge, approximately 52% of patients were diagnosed with epilepsy. Neurocognitive impairment emerged as prevalent consequences of new onset refractory status epilepticus. Now, the most common etiologies of seizure, it's anti-seizure medication related 16 to 35%, unprovoked seizure 15%, alcohol and benzodiazepine withdrawal 5 to 20%, brain tumor 14%, cerebrovascular disease 8 to 14%, metabolic and toxic cause 4 to 15%, systemic infection 5 to 7%, traumatic brain injury sequelae 5%, CNS infection 3%, and de novo status epilepticus cerebrovascular disease 32%. Then other causes are brain tumor 3 to 18%, drug intoxication 5 to 20%, unknown etiology 5 to 10%, alcohol benzodiazepine withdrawal 6 to 10%, metabolic or toxic 6 to 10%, traumatic brain injury 7%, CNS infection 5 to 9%, inflammatory disease 6%, undetermined cause 5%, systemic infection 2%, neurodegenerative disease 2%. Then diagnosis, it has been shown that 42.5% of status epilepticus cases require specific treatment for underlying cause, in addition to stopping seizure and providing symptomatic treatment. It is crucial to quickly identify underlying cause of status epilepticus. Sometimes thorough evaluation may be necessary, especially in cases of status epilepticus occurring in patients with de novo status epilepticus. Approximately half of the status epilepticus cases occur in patients with epilepsy, while other half are new onset cases. It is essential to determine whether the patient has history of epilepsy or not, and thus comprehensive medical history and complete neurological examination are imperative. Focal abnormalities may suggest structural brain lesion. Vital sign and general physical examination, including skin examination, may be informative in revealing indirect sign of drug intoxication, injection site, or purpura. It is necessary to perform brain imaging for all patients and conduct basic lab tests to rule out major acid-base disturbances, electrolyte imbalance, acute organ failure, and intoxication. Whenever possible, MRI should be favored over other imaging technique as it is more sensitive in diagnosing certain underlying causes. In some cases, MRI can provide a physiopathological insight, such as detecting evidence of ictal and post-critical neuronal damage. In such a cases, there are usually visible T2 hyperintensity involving the cortex, adjacent white matter, basal ganglia, thalamus, corpus callosum, and cerebellum, indicating vasogenic and sometimes cytotoxic edema. In patients with known history of epilepsy, rapid and favorable evolution, brain imaging might not be required. In patients with epilepsy who experience occasional breakthrough seizure and for whom no other underlying cause for their status epilepticus has been identified, through medical history, basic lab investigation, and neuroimaging, lumbar puncture might be considered. In patients presenting with de novo status epilepticus, the threshold for performing lumbar puncture should be set even lower. Additionally, any patient with suppressed immune system or exhibiting antecedent infectious symptom, language difficulties such as fever, hypothermia, should undergo cerebrospinal fluid analysis to rule out central nervous system infection. Interpretation of CSF analysis results may be subject to debate, especially in the presence of moderate pleocytosis. Pleocytosis and increased concentration of lactate and albumin CSF serum ratio in the CSF are sometimes described in post-ictal phase in the absence of any infection and vascular pathology. However, these pleocytosis remain uh, moderate, rare, early, and is not influenced by duration and type of seizure. So it is imperative to obtain EEG at earliest opportunity. EEG plays a critical role in determining the treatment option, aggressiveness, and prognosis. Although certain type of status epilepticus can only be accurately diagnosed through EEG evaluation. In convulsive form of status epilepticus, the EEG is often affected by movement, muscle artifact, and making its interpretation difficult. However, in the case of non-convulsive status epilepticus, where clinical signs are often subtle and non-specific, EEG becomes essential for accurate diagnosis. Now, investigation for new onset refractory status epilepticus. General investigations are complete blood count, glycemia, liver and function test, electrolyte, and anti-seizure medication trough. Then if you are suspecting autoimmune etiology, then intracellular antineural autoantibodies, then surface antineural autoantibodies, then systemic autoantibodies should be sent. If you're suspecting infectious cause, then we need to send viral panel, bacterial panel, parasites, fungal, and adapt serologies to patient's travel history. So viral include HSV1, HSV2, VZV, CMV, EBV, then this HHV6, enterovirus, measles, rubella, influenza A and B, HIV, JCV, flavivirus, hepatitis C. Then bacterial include Lyme, syphilis, Mycoplasma pneumoniae, chlamydia. Parasites include Toxoplasmosis and blood spot. Fungal include Cryptococcus neoformans antigen. Other causes are porphyria, lactate pyruvate, mitochondrial mutation genes such as MELAS, RRS, and pole gene, and then heavy metal test. CSF general examination includes CS cell count, glucose, protein, oligoclonal band, gram staining, cytology, India Inc. Then autoimmune intracellular antineural autoantibodies and surface antineural autoantibodies. Updating antibody panel on the regular basis is crucial to keep up with latest discoveries of the new antibody. If infectious cause we are suspecting, then we need to send PCR panel for virus, PCR for FB sputum strain, Listeria monocytogen, Mycoplasma pneumoniae, Lyme antibody, Cryptococcus neoformans antigen, and others are lactate pyruvate ratio. The most frequently encountered etiologies are non-paraneoplastic autoimmune pathology and paraneoplastic autoimmune pathologies associated with various synaptic and intraneural autoantibodies. Antibodies directed against neuronal cell surface antigen are inherently pathogenic. This category include antibodies that bind, for example, to NMDA receptor, leucine-rich glioma inactivated, and GABA-B receptor. The mechanism underlying seizure generation remain partially elusive, but research suggests that anti-NMDA receptor antibodies have potential to trigger receptor internalization. Anti-LG1 antibody may cause disturbance in synaptic protein localization, and antibodies against GABA receptor can serve as antagonists for neurotransmitters. So antibodies against glutamate decarboxylase as well as classic onconeural antibodies that target intracellular neural antigen such as antibodies against UURMA, SRY box transcription factor 1 and amphiphysin have varying degrees of association with different types of tumor. Unlike antibodies that bind to neuronal cell surface antigen, that is onconeural antibody that are believed to primarily reflect epiphenomenon of underlying immunocascade, in which cellular immunity, specifically cytotoxic T cell infiltration, granzyme mediated damage may play a leading role. Although autoimmune inflammatory etiology have received lot of attention recently, it is important to remember that they represent 2.5% of status epilepticus. It is thus important to look for it in right clinical context. Rare mitochondrial disease such as MELAS, MERRF, and the Paul G1 may initially present as a de novo status epilepticus in adult. Given the variety of underlying cause of status epilepticus, the use of diagnostic guide may be used. The status epilepticus etiology identification tool question has been developed for use at patients' bedside in emergency setting. The questionnaire was evaluated in cohort of 212 cases of all types of status epilepticus. Based solely on information available in emergency department, it was correctly identified the underlying cause. Then the treatment. Principle of time is brain holds utmost significance when dealing with convulsive status epilepticus. So quick administration of symptomatic treatment is imperative and may need to be escalated to anesthetic to avoid severe metabolic disorder and long-lasting effect beyond the time T2. The basis of the recommended stage treatment approach lie in the pathomechanism of status epilepticus, characterized by the malfunctioning of GABAergic neurotransmission and the overactivity of glutamanergic signal. So the treatment plan suggests benzodiazepine should be administered immediately after diagnosis of status epilepticus as first line treatment via intravenous and alternative route, followed by IV non-sedating anti-seizure medication. The primary treatment in the advanced stages is the use of anesthetic drugs to induce therapeutic coma. Furthermore, critical care management, along with other therapeutic options such as immune therapies and dietary intervention, offer crucial supplementary treatments. So, first stage is benzodiazepine. Typically, benzodiazepines are first line treatment in the initial phase of status epilepticus due to their rapid onset, effectiveness, and tolerance. Even though benzodiazepine work as a allosteric regulation at inhibitory GABA aminobutyric acid GABA A receptor, the diverse agent possess unique pharmacokinetic and pharmacodynamic characteristics, leading to varying effectiveness profile. Clonazepam, diazepam, lorazepam, midazolam are conditional benzodiazepine, differing mainly in the routes of administration and duration of their effect. If IV therapy is not feasible, benzodiazepine can be administered via intramuscular, oral, rectal, nasal, and buccal route. Various control studies have been conducted to compare effectiveness of different benzodiazepine in the treatment of status epilepticus. So, according to Rampart study, intramuscular benzodiazepine, that is 10 mg in adult and 4 mg in children, was found to be as effective as intravenous lorazepam, that is 0.1 mg per kg, in managing status epilepticus among pre-hospitalized patients. A concurrent meta-analysis has conducted that lorazepam is more effective than diazepam. Among benzodiazepine, lorazepam is the preferred choice for IV therapy, midazolam for IM therapy, and diazepam for rectal therapy. Because there is no IV formulation available, clonazepam is most commonly used in United States. However, in one study, clonazepam appeared to be effective alternative option to lorazepam and midazolam as initial treatment option for status epilepticus. In this study, it was observed that lorazepam was associated with higher probability of refractoriness and increased requirement for additional ASM to manage status epilepticus compared with clonazepam, most likely due to underdosing of lorazepam. However, the effectiveness of clonazepam and midazolam appear to be similar. Further evidence supporting the use of clonazepam has emerged from the SAMU-KEPRA study. The study evaluated effectiveness of clonazepam alone versus combination of clonazepam and levetiracetam in terminating seizure within 15 minutes time frame. It was observed that clonazepam alone was able to abort 80% of seizure and there was no added benefit observed when Keppra was added to treatment. Underdosing of benzodiazepam during initial stage is prevalent occurrence that has correlation with subsequent development of refractory status epilepticus. Increased use of second line anti-seizure medication and longer stay in intensive care. Now non-sedative anti-seizure medication. In around one-third of patients, benzodiazepine may not be effective in treating seizure. Therefore, urgent administration of anti-seizure medication is necessary in all patients with status epilepticus, except if cause of status epilepticus is identified and definitely treated. If patients respond well to initial therapy and status epilepticus is fully resolved, the objective is to quickly reach the therapeutic level of anti-seizure medication and continue administering maintenance therapy to avoid seizure recurrence. Anti-seizure medications such as phenytoin and fosphenytoin, valproate, levetiracetam has been utilized for several years. However, there has been lack of comparative solid data and guidelines were mainly based on cohort or observational studies. In 2019, the ESSET trial comparing phenytoin, valproate, and levetiracetam was equally effective in controlling status epilepticus. They were successful in approximately 50% of patients with benzodiazepine refractory to status epilepticus. Meta-analysis of 5 randomized trials established that there was no significant difference in seizure cessation between second-line therapies. Both levetiracetam and valproic acid ranked highest for safety, although limited data made it challenging to draw firm confirmation about uh, lacosamide. If in a small study that focused the repetitive seizures in coma detected on continuous EEG, IV levetiracetam 400 mg and phenytoin 20 mg per kg were found to be equally effective in controlling seizure and had similar side effects. Sorry, there was one mistake. In a small randomized study that focused on repetitive seizure in coma detected on continuous EEG, IV lacosamide 400 mg and phenytoin 20 mg per kg were found to be effective in controlling seizure and had similar effects. Recently, the use of off-label lacosamide has demonstrated success in multiple reports of status epilepticus and refractory status epilepticus. So, newly approved anti-seizure medications such as brivaracetam and perampanel may represent potential benefit in management of status epilepticus. However, additional research is necessary to establish the exact role of these new anti-seizure medication in status epilepticus management protocol. In summary, levetiracetam 60 mg per kg, valproic acid 40 mg per kg, phenytoin 20 mg per kg have solid evidence of efficacy. The fast-acting anti-seizure medication like lacosamide and brevacetам can also be used. Now, therapeutic coma. The management of refractory generalized status epilepticus is well established. If initial ASM anti-seizure medication is failed to control seizure, the appropriate course of action is to administer benzodiazepine, propofol, and the pentobarbital as required. Similarly, if non-convulsive status epilepticus occurs following generalized tonic-clonic status epilepticus, initial anti-seizure medication are ineffective and it is advisable to pursue highly active treatment. After tracheal intubation, it is crucial to restore pharmacological induced coma with IV anesthetic, not only to protect airway, but also to prevent potentially harmful systemic metabolic repercussions. The use of therapeutic coma as a routine treatment remains debated. Several observational studies have suggested that therapeutic coma may be independently associated with increased mortality rate and significant prolongation of hospital stay without any observable benefits on patient survival. Therefore, in cases where there is no history of convulsion or when seizure activity is exclusively non-convulsive, adding non-sedative ASM may be considered as an alternative, less aggressive treatment option. According to retrospective study, there was no observed correlation between most commonly prescribed general anesthetic and patient outcome. In retrospective study comparing midazolam and thiopental, the equivalence in efficacy was proven. However, thiopental was associated with high risk of hypotension, infection, leukopenia, and hyponatremia. Generally, midazolam, even at the doses exceeding 1 mg per kg per hour, and propofol, particularly at infusion rate below 5 mg per kg per hour, are safe. Therefore, it may be prudent to initiate treatment for patients with refractory status epilepticus with midazolam before considering the use of barbituric for those with super refractory status epilepticus. During therapeutic coma, EEG monitoring is critical and mandatory. EEG target can be categorized into three levels of increasing electrical suppression, that is seizure suppression only, bird suppression, and complete suppression. Previous research suggested that patients who achieved complete EEG suppression had lower risk of relapse of status epilepticus. However, most recent evaluations have indicated that patients who were treated without targeting burst suppression or complete suppression fared better. In very recent study, more than 50% of EEG suppression was achieved in one-fifth of 147 refractory status epilepticus cases. However, reaching this level of sedation was not associated with persistent seizure termination or survival. This once again suggests caution in adapting deeply sedative strategy. Given this uncertainty, since the degree of EEG suppression may serve surrogate for medication dosage, lead to iatrogenic complication, it is reasonable to conclude with limited available evidence that seizure suppression is better option than birth suppression and complete EEG suppression. A recent study found that longer duration of EEG suppression was associated with higher likelihood of successful win. After maintaining desired EEG target for 24 to 48 hours, gradual reduction of anesthetic agent is recommended, typically over 6 to 12-hour period, while monitoring the EEG for any sign of seizure recurrence. It is important to note that during weaning process, de novo periodic discharge with the periodicity of 1 to 4 hours and triphasic appearance may appear on EEG, but these are not indicative of epileptic activity and tend to resolve spontaneously. In conclusion, therapeutic coma is a valid option in selected situation. A reasonable initial approach would be aim for seizure suppression for 24 to 48 hours by utilizing combination of midazolam and propofol. It is important to note that continuous midazolam in the dose of 0.2 to 0.4 mg per kg and propofol in the dose of 2 gram per kg. It is important to note that continuous EEG monitoring should be implemented during this process. Thank you, guys.